and we will start right at 8. All right. Good morning. Good morning, everybody. This is Kate Elliott. I am a program manager with Patient-Centered Primary Care Institute, and here to welcome you to our webinar this morning, POLST, What's New and How Can We Do Better? Before we get started, a couple of notes about the technology. So there are about 35 folks on the webinar today and growing. So everybody is on a global mute. That doesn't mean that we don't want to hear from you, though. So we would love to hear your questions. So at any time during the presentation, if a question comes up, please feel free to type it into the questions pane in the GoToWebinar control panel. That allows me to kind of sort through questions, and that way we can get going with your questions right as Q&A starts. So no need to wait until Q&A at the end. Go ahead and send those questions in as they come to you. One question I know we'll get is whether or not the slides will be available after the presentation, and the answer is yes. The slides and a recording of this webinar will be available on the website starting tomorrow, along with some links to some resources that our presenters will talk about today. The quick commercial is that this webinar is hosted by the Patient-Centered Primary Care Institute, which is a partnership with the Oregon Health Authority, specifically the PCPCH program, to get technical assistance and resources out to folks working on the Patient-Centered Primary Care Home, or PCPCH, or medical home model of care. Clearly, you've been to our website if you're on today's webinar, but if you haven't poked around, you should. There are a series of online learning modules, recordings of webinars, much like this one, more than 20 at this point, and a series of resources in addition to information about in-person training opportunities as they become available. So we definitely encourage you to visit the website and sign up for our newsletter so that you get updates about things available to you there. Like I mentioned, the Institute works closely with the OHA PCPCH program, which is the state's program to recognize primary care homes. The PCPCH model is defined by 6 core attributes, and within those 6 attributes, there are 33 standards that practices attest to in order to become recognized. You can learn more about the program on the program website, which is listed there at the bottom, primarycarehome.oregon.gov. And without further ado, I'd like to introduce at least our first presenter, who will introduce us to the rest of the folks who will be presenting today. Dr. L.J. Fagnan is a professor of family medicine at OHSU. Prior to joining OHSU, he was a general medical officer in the Indian Health Service in Bethel, Alaska, and a family physician in rural Oregon. His practice in Reedsport, Oregon was founded in 1977 and was one of the 13 model rural practices funded by the Robert Wood Johnson Foundation's Rural Practice Project. In 2002, he was selected to start a practice-based research network at OHSU, the Oregon Rural Practice-Based Research Network, or ORPRN, a great friend of the Institute. Network membership in ORPRN includes 170 primary care clinicians and 51 practices, which care for more than 250,000 patients and are located in 40 Oregon communities. During the past decade, Orphan has conducted over 20 projects studying the elements of medical home. These projects have used a team approach to effectively use health information technology and data to improve quality of care, including the patient experience of care. So we are definitely in good hands today, and I will go ahead and welcome Dr. Fagnan to get us started.
Thank you, Kate. Good morning. Our webinar today, as Kate mentions, is about the use of the POLST in primary care practice. What's new and how can we do better? Providing expert commentaries, Dr. Susan Tolle, a general internist at Oregon Health and Science University and director of the Center for Health Ethics. Joining Dr. Tolle are two family physicians that have considerable experience in implementing the POLST form in practice. Dr. Gary Plant, a family physician with the Madras Medical Group in Madras, Oregon, and Dr. Joyce Hollander Rodriguez, family physician and director of the Cascades East Family Medicine Program in Klamath Falls. The team at the Oregon Rural Practice-Based Research Network makes home visits to your practices. On these visits, we frequently facilitate practice and quality improvement projects. We've observed that projects involving shared decision-making, the patient experience of care, and building patient self-management support have identified end-of-life discussions and the appropriate use of advanced directives and physician orders for life-sustaining treatment as areas for improvement. In addition, I get to listen to medical students come back from their rural and community clerkship programs and debrief, and many of these students have turned to the topic of end-of-life discussions and processes for the required project. In looking at these activities, we found considerable variation between practices across the state, and to me, what's even fairly interesting is that variation exists within the practice on how the POLST form is introduced and implemented. What's happening in your practice? In addition to addressing variation in practice, we're having this discussion because our patients' wishes are not being recognized. On the POLST website, that'll be shared with you a little bit later, it's noted that 70% of people say they prefer to die at home, yet 70% die in a hospital or long-term care facility. 82% of people say it's important to put their wishes in writing, and yet only 23% report having it done. What is the responsibility of primary care clinicians and their practices for having end-of-life discussions and doing it well? Recently, the February 12th issue of the New England Journal of Medicine presented a case vignette of a 59-year-old woman with metastatic breast cancer who's running out of treatment options as her disease continues to progress. In discussing prognosis, it comes time to have a frank discussion about end of life. Three perspectives were presented: the primary care physician, the oncology team, and the palliative care physician. Dr. Susan Tolle, our presenter today, made the case for primary care. There was an online poll asking what course of action should occur with the patient. 52% responded that it's the primary care physician's role to discuss the goals of care with the patient. 6% voted that the oncology team should discuss the goals, and 20% recommended referring the patient to a palliative care physician to discuss the goals. It was great to see that Susan was successful in making the case for primary care. These difficult conversations require the presence of a primary care physician. It is our job to see the patient through the end of their life. There's considerable joy in participating in a good death. In an effort to do our job well, I'm really pleased to introduce Dr. Susan Tolle. As I mentioned, she's the director for the Center of Ethics in Healthcare at OHSU. Susan has rural roots. She was born at the Tillamook General Hospital. She's nationally recognized for her work in improving caregiving and the end-of-life experience. Just yesterday, Dr. Tolle was in the New York Times in discussing the troubles with advanced directives and where the POLST fits in. I'll now turn things over to Dr. Susan Tolle.
LJ, thank you so much. It's my great pleasure to be here, to be part of this group. There we go. To be part of this group and to have an opportunity to reconnect literally with colleagues all around the state who are as passionate as my fellow panelists about being sure that we do what patient wants at each chapter of their lives. The Center for Ethics in Healthcare does not accept funding from healthcare industry sources, and that has helped people be much more trusting of where the POLST program may be coming from. I personally and our center doesn't make any more or lose any more money if someone fills out a POLST form and says they want everything, or if they prefer to limit treatment. In some of the conversations in DC in recent years about whether or not physicians should be paid for their time and having these conversations and some of the controversy, this financial base has become more important. And I couldn't resist including a scene from my roots at the Oregon coast. As we prepare for what we're going to cover this morning, I'd like to remind you that we had very much encouraged that you watch a 5-minute video called Understanding POLST before joining our webinar. That video offers an opportunity to educate patients before an office visit or perhaps between visits as they're reflecting on this, look at it with their families, hopefully have a more thoughtful and knowledgeable conversation with you. But we also appreciate that as a primary care provider myself, I understand that every minute in the clinic day is a bit pressured these days, and it seems that intensity is growing. So anything we can also do to improve the efficiency of the physician's time in having these conversations by making them well-informed and incorporating the video. We know that in many regions of the state now, hospice has loaded this understanding video on their computers, and when they go out to the homes, they're showing this to patients and families as conversations about POLST completion and enrollment in hospice are taking place. And if anybody wants it within their hospital system, we are happy to design ways to help you get it behind any firewalls you may have, because it shows in online closed-circuit videos here now, for example, at OHSU in the inpatient setting, and we are giving it also to Providence. We give it away. There is no charge for this, and we'll help you download it in any way you want. But we are finding that it's a valuable time saver. And there are links to find that resource posted on the screen now. We're going to review some new POLST research findings once we really understand how well POLST works and how much more effective it is than advanced directives have ever been. The motivation to complete them and be able to find them goes up. We'll talk briefly about finding POLST on admission, these forms that many of you have spent time carefully completing are obviously designed to move from outpatient, from home, from long-term care facility, from home hospice to inpatient settings where they guide treatment as patients move from one setting to another. We'll talk about some of the challenges of needing to complete POLST at hospital discharge, and then Gary and Joyce will provide us a lot of insight about efficient ways, effective ways, and how to move these conversations forward in what all three of us personally regard the most appropriate setting most of the time, which is the outpatient setting. As LJ said, there is general agreement that patients, particularly near the end of life, have a right to make decisions about whether or not they want medical treatment. That's been agreed to for more than 25 years by national bioethics leaders in the courts, and it just wasn't happening. You had a right to it, but we couldn't effectuate it. That's why, as LJ gave some figures, so many people end up dying in the hospital, more so in other states than in Oregon. But still, a third of Oregonians do die in an acute care setting, and more than we would like, that is in an intensive care unit. Large national studies have surveyed Americans, older adults, asking them what their preferences would be, and less than 10% say, my wish, my desire is a death in the hospital setting. There are people who want that, but it's a very small number relative to the overall population. So our challenge today is to look at the fact that across the country, more than 4 times as many people end up dying in the hospital as have said that is what their goal would be. Let's take a minute and look at the role of advanced directives, what they do and where they fall short. Advanced directives are for anyone 18 or older who is cognitively intact enough to be able to complete an advanced directive. It's not unusual for people to complete an advanced directive and 10 years later it still names the correct people and reflects the wishes they want. But periodically it may need to be updated. I recently had a patient where both of the people she had appointed had died. And there are times where it needs to be revisited because of changes in often the person who has been appointed. But as one becomes much more advanced in a chronic illness or much more frail, and this can be at any age, including babies who are born dying, POLST does not have an age restriction, but it's for someone who is ready to turn wishes into action. Tonight found down, I do or do not want specific medical treatment. POLST is not a form. It's a process. It's a program. Education needs to accompany this. Systems need put in place to be able to find it. And it's a process in that many people change their mind as their health status changes. 500 of the 3,500 POLST forms loaded every month in the POLST registry, 1/7 of them are revisions of an existing form. It is not at all unusual for people to change their mind, often as they get sicker, setting more limits, but sometimes people make a greater recovery from a stroke or something else and actually change their mind requesting more treatment. So the changes are in both directions, but the majority is further limits. Before I talk in some depth about the shortcomings of advanced directives, which were extensively discussed in this week's New York Times article, I'd like to talk about 2 things advanced directives do that are extremely important. One is they lift an emotional burden from family members. We have formally interviewed 6 months after death family members who made a decision to stop a ventilator on a loved one. And we looked at whether they had any knowledge directly from the patient about what the patient would have wanted. And then we looked at whether it was verbal or written. and measured their stress levels on a formal instrument that's been used for all kinds of disasters and other kinds of stress, like the Berkeley-Oakland firestorm. And people rated the same level of stress, distress, waking up at 2 in the morning, did I do the right thing, as if their home had been burned in the Berkeley-Oakland firestorm, if they had no idea what their loved one wanted. No prior conversations, no verbal, no written. And they made the decision. Family members do not do well in that context, and they have a lot of self-doubt. The other thing that advanced directives do that POLST does not do is appoint a legally authorized surrogate. We all know that families come in many sizes and shapes and many levels of agreement and difference within those families. We also know that there are some families where there may be a common law wife of many years, but on Oregon's default, that individual would be at the bottom of the surrogate list. So there are clearly some people where the appropriate surrogate would not be turned to in default, who benefit enormously from completing an advanced directive. One of the most challenging questions about the POLST paradigm is who should have a POLST form. And actually one of Oregon's greatest challenges is Oregon's tremendous success. Over 200,000 POLST forms have been submitted to the Oregon POLST registry in the little over 5 years it's been in operation. One of the challenges now is that with the data showing how effective POLST is, there is a little bit of an attitude, a little is good, a lot is better, and offering POLST forms to patients who should be completing advanced directives and who are too healthy to have a POLST form. The reason not to ask someone to complete a POLST form who is too healthy to have a POLST form is that they are thinking about future events, not present events, which is what an advanced directive is designed to do. And this is orders to EMS for tonight found down. Do I or do I not give CPR to this patient? Do I or do I not intubate this patient? Do I or do I not transport this patient to the hospital? Not if anything. These are orders right now, whatever I see. And that means that a 65-year-old who has no advanced progressive illness and no advanced frailty mostly wants to know what's going to happen to make a decision, will I recover? Because if I don't recover, then there are things I don't want. That's an advanced directive. That's not a POLST form. If you completed a POLST form on that individual, you would mark yes to everything. And if you mark yes to everything, you don't need a POLST form because that's what EMS is going to do anyway. But you may put an extra burden on families because here's a form that says I want everything and the patient signed it and the doctor signed it. So there are times where that has delayed withdrawal of life support that the patient likely wanted. While we sorted out, did they mean everything now in their new state of health after the massive stroke, that kind of thing. So I encourage people to offer POLST forms to persons who qualify as, I wouldn't be surprised if they died in the coming year, they have advanced frailty, and while they may live several more years, clearly they are so frail that CPR would be unlikely to be successful and they don't want it. So we're looking at a population that is more in advanced illness. Now the surprise question is carefully worded. I would not be surprised if my loved one died in the coming year. That is worded to mean I also might not be surprised if they lived another couple of years. It's heart failure, it's COPD, it's those exacerbations and rescues. I can't really say how long this patient will live. It's not that they have widespread cancer and have decided against further treatment and are hospice eligible, and the trajectory looks relatively clear. This organ system failure group is incredibly hard for us to predict what their prognosis is with any exact science. It's not unusual for a patient with advanced heart failure to have the best day they've had in several months and have an arrhythmia that night and sudden cardiac death. So this is a group of people where we cannot make reliable predictions, but if we wouldn't be completely blown away that we got a call from the coroner that the patient died, they are a potential candidate to consider having a POLST form and record their wishes for those kinds of sudden events. Now there are individuals, so I've talked about who do we reach out to. You will find individuals with only moderate frailty who feel extremely strongly and wish to take the initiative and request the opportunity to have a POLST form because they are absolutely certain they don't want to go to intensive care. They've seen several other people in their assisted living facility do that. They do not return to any kind of independent living in their mind, and they want a POLST form. That's different from actively recruiting, from putting markers in your charts, from deliberately trying to find a POLST-appropriate population. And some of those individuals who feel very strongly need redirected, like the healthy 65-year-old, to have an advanced directive. And the person with moderate rather than advanced frailty whose value system is very strong, I personally would give a POLST form to. But I wouldn't necessarily reach out to them. Oregon changes its POLST form with new information, new technology, about every 3 years. This is the current Oregon POLST form. On the bottom of the form, you'll see the date is 2014. It was issued in October. And all current people who have POLST forms completed with earlier versions, those are all valid. This is just a little more effective for one reason or another. It's the 9th version. About 3 years from now, we can expect a little update. We do ask people to throw away blank forms that they have and replace them with this one because it's for a reason that we're making these upgrades. Our data has shown that doing something slightly differently is a little more effective. Patients understand it a little better. It's a little clearer. And in this document, we are upping the ante on the signer. All other states but one actually require the signature of the patient or surrogate. We recommend it, but we don't require it. It's a tremendous emotional burden for some families to actually sign for a loved one, and this allows them to agree but not actually put pen to paper. Sometimes family are on the phone and not physically present in another state, and so the logistics seemed wiser, but the physician has to attest that they have actually spoken to someone and check a box who they spoke to, which is upping the ante from the prior 8 versions. There's a little bit of other change in language that makes some things more understandable. Let's talk about where POLST forms are coming from. Last year, submitted to the Oregon POLST registry, these are the numbers coming from every county of people who we have an address for. There are a few more that come in and we have no address on the form and can't tell who we should give credit to. But if we look at percent of over age 65, we get a tremendous sense that all across our state there is good participation in both the POLST program and submission to the registry. I think this is a fairer way than the numbers to make a comparison. And the number, as I've said before, should not be anything close to 100%. My guess is that only about 15 to 20% of people who are age 65 should have a POLST form. and this is all persons over the age of 65 who have a form in the registry. We remove those that we know are deceased, but there are a number who are deceased we cannot find, so there are some people who are counted who are not living. POLST was created in Oregon, and we're honored that the Institute of Medicine report that came out in September looking at death in America and talking about the many problems that are faced formally made POLST a recommendation number 4 that other states adopt the program. It is so effective. There are only 2 mature programs in the country, Oregon and West Virginia. Mature means any part of your state, any hospice program, long-term care facility, or hospital has access in their region to POLST and is actively using the POLST program. And it's 100% for Oregon that all hospice programs use it for some of their people that they are serving. The same is true for long-term care and acute care hospitals. So it started in Oregon. It started in our office now over 20 years ago. And it's exciting to see how much it has benefited others. And we are honored that national media such as the New York Times this week have featured the POLST program, recommended it for those with advanced illness and frailty, and described the national rollout. What I'd like to do now is to show you why that strong momentum is gaining force. I'd like to honor my research colleagues, Eric Fromey, Dana Zive, Terry Schmidt, Jennifer Cook, in doing this study that looked at the association between physician orders for life-sustaining treatment and in-hospital death. Most recent studies of advanced directives have shown that if you have one or if you don't have one, you are just as likely to die in a hospital. So advanced directives do not prevent in-hospital death. They enhance the opportunity to have a conversation, lift a burden from families, and to do excellent planning about withdrawal of treatment in the hospital in a more informed and supportive manner. And they probably shorten the time someone is in the hospital, but they don't keep you from dying there. We looked at the first 2 years of operation of the Oregon POLST registry and matched death certificates to people in the registry. At the time, in the first 2 years of operations, it was 31% of Oregon deaths, 18,000 Oregonians from all reaches of our state, every county being represented. And we asked, okay, advanced directives have no association between location of death. How strong is the association between what you mark in Section B and where you die? This is why the Institute of Medicine said every state should adopt POLST. What this slide shows is percent of people dying in the hospital. The first 3 bars are people with POLST forms and how those POLST forms were marked. And the 4th bar is people who have no POLST form in the registry and what happened to them and where they died. Anchoring Oregon because our data does show lower rates of death than the rest of the country in the hospital, with what happens here, which is the only fair comparator for us. You will see a mind-blowing, statistically significant difference between the 11,836 people who marked comfort measures only on their POLST form, and of whom only 6.4% died in the hospital. And the group marking full treatment on their POLST form, where 44.2% died in the hospital, a rate 10% higher than those with no POLST form at all. So POLST doesn't keep you from getting treatment, but it certainly lines up with what you mark and the treatment you receive. There are a lot of questions asked about those who did die in the hospital and said they wanted comfort measures only and said they didn't want to go back to the hospital, and why some of them are still dying in the hospital. My personal clinical experience is that about 1 time in 20, about 5% of the time, a patient dies in a way that I cannot manage their comfort at home. They won't stop seizing. They are vomiting blood. They fell and they fractured their leg. They cannot be appropriately cared for with dignity and comfort at home. I have to move them, and they may be near death, and they may die at the hospital. I had guessed this number, if we were near perfect, would be 5%. That's pretty darn close. There are times where people panic, go to the emergency department over the wishes of the POLST, and we certainly hear about that with great passion from our EMS and emergency department colleagues. But if you look at the big pictures of the numbers, we are greatly reducing what used to happen. The trends are the same if we look at every cause of death in the top 10, heart disease, lung disease, kidney disease, dementia, cancer. But the rates of use of POLST vary by diagnosis. People with heart disease are half as likely as people with cancer to have a POLST form. In the last 3 slides, before I turn this over, I'd like to comment on the fact that you do such tremendous work in outpatient settings. It's vitally important that POLST forms be able to be located for those being admitted to the hospital. Increasingly larger health systems are putting a POLST yes/no button on the top of the header. And we also have the ability to call the statewide registry, and here's what the call center sees on their screen when EMS or an emergency department calls them. They provide this and can fax it to the facility, but we need to be sure they're being checked on admission in the facilities that you admit to. Deploying POLST appropriately on discharge. Our goal is that POLST reflects the true and deeply held wishes of the patient and isn't something that is put together minutes before discharge to a skilled nursing facility without a thoughtful conversation with the patient and the family and the kind of time that you have to reflect when it is done, often over more than one visit, and often in a way that is both more thoughtful and with people they know and trust in an outpatient setting. And with that, I'd like to turn it over to 2 people who are very much experts in how advanced care planning can take place in an outpatient setting, integrating educational materials in advance, thoughtful goals of care conversation, and not only have what's marked on the POLST form respected, but assure that it actually is what the patient wanted. And then to be sure that once these thoughtful conversations take place, orders can be found in every setting of care in your community, honored and respected. It is my great pleasure to turn the microphone over to Gary and Joyce, and I look forward to your questions at the end.
So Susan, this is LJ, and I really appreciate you sharing this overview and perspective. I want to remind folks on the phone that there's opportunity to write questions in the box, in the question box there, as you think about the POLST in your practice. I'm going to introduce 2 family physicians, Dr. Gary Plant and Dr. Joyce Hollander Rodriguez. I'm going to introduce both of them together, and then Gary's going to talk about what the conversation is like, who's having this conversation, and Joyce is going to talk about how this really is structured in the office and some of the logistics and standard procedures. Both Gary and Joyce had the opportunity to bring new life into the world, delivering babies, and also to care for people at the end of their life. Want to talk about Gary for a minute. Dr. Plant, graduate of Philomath High School. These are small town rural roots you're going to hear about. And then at East Tennessee State University for his residency, and now with the Madras Medical Group in Madras. And Gary has been past president of the Oregon Academy of Family Physicians and has spent 3 years as the Oregon Academy's liaison to the Oregon POLST Task Force. Joyce Hallner Rodriguez is a family physician and director of the residency program at Cascades East Family Medicine in Klamath Falls. She's a graduate of that program. Importantly, she's a graduate of Pleasant Hill, Oregon High School, where she grew up. Joyce is certified in hospice and palliative care and as medical director of the Klamath Hospice. So two physicians that have a fair amount of experience with this, and I'd like to turn things over to Gary to share his experience and perspectives. Dr. Plant.
Thanks, LJ, and good morning, everybody. I want to talk about how these conversations happen in the office setting. First of all, who we have the conversation with. As Susan already alluded to, we think about patients who are, it wouldn't surprise me if they died in the next year. Now, obviously, I don't start the conversation with Mrs. Jones saying, you know, it wouldn't surprise me if you died in the next year. But the conversation may start with, Mrs. Jones, you have a disease that I can't make go away. Your heart failure or your cancer or your dementia, your COPD, your advanced renal disease is likely to be the disease that ultimately ends your life. And I'd like to find out what your wishes are if and when that happens. There's a couple of ways that I frame the conversation. If it's a patient that I know really well, I may be more frank about the conversation. And if it's a patient that I don't know as well or I don't have as strong a sense of what their wishes might be, I'll frame it a little bit more gently. So the patient that I know well and I have a good sense that they probably wouldn't want further interventions, I may simply ask the question of how many times do you want to die? If you're clinically dead, do you want me to try to bring you back so you can do it again? That's not how I typically have that conversation. With most of my patients, I will start by saying that we want to make sure that we do everything for you that you want, and we don't do anything to you that you don't want. And so we go through this POLST form to try to clarify those wishes in the case that you're found down unresponsive and are unable to tell us what those wishes are. As you go through this list, there's really 3 questions that you're asking, and the top question is the most important one, and incidentally is the only one you have to have in order to have a valid POLST form, and that's the question of resuscitation. And so I'll ask the patient, if you are found down, not breathing and with no pulse, which means you are clinically dead, do you want resuscitation? And I'll describe what resuscitation means. That means we would do chest compressions, we would put a tube down your throat and try to breathe for you, we would shock the heart and use medications to get it started again. I'll often explain that if I were to drop suddenly with a cardiac arrest in my current state of health at my current age, which is almost 40, I have about a 50-50 chance of surviving that incident and going on to come home and live a relatively normal life. Somebody with advanced disease may have more like a less than 1% chance, and so I'll frame it in that role that here's the likelihood that you go home after an event like this. Now, do you want me to try to bring you back to that state of health? The second question regards, what if you're not dead? What do we do up to that point? And there's 3 options, and the way I describe those are comfort measures is for people who are no longer wanting to try to fix anything. they are more focused on eliminating suffering and accepting that this is the end of their life. That may be a cancer patient, it may be a patient on dialysis, it may be a patient who is coming off of dialysis, a patient who has end-stage heart failure or end-stage lung disease, and they really don't want to try to fix anything. They just want to make sure they don't suffer and they die with dignity. Those are patients that comfort measures are appropriate for. The other end of the spectrum is full treatment, and those are the patients who say, I want you to do everything you can to keep me alive as long as possible. And then I describe the middle of the road approach, which I find most patients lean towards, which is limited treatment. That means if you get sick, if you have a pneumonia or a urinary infection or a cardiac dysrhythmia, I'm going to do the things I can to try to fix that problem for you. But if that problem progresses and the things we're doing aren't working, I'm not going to go on to full treatment and resuscitation. And the last question is the artificially administered nutrition. And I describe that again with the three-pronged approach. We can do nothing and say, I don't want any artificial nutrition. We can do everything and give you artificial nutrition as long as we can to keep you alive as long as we can. Or we can take a middle-of-the-road approach where we may say, you know what, we're going to give you artificial nutrition for a week until your broken jaw heals up enough that you can eat something. And then, but if it goes on longer than that, or if you don't respond from our treatments, you're not recovering from your stroke, then we would stop at that point. And so we go through those three questions in that way. And I find that patients, if you walk them through the form, they usually have an idea about what they would want in those situations when you present it in that way. And I'll turn it over to Joyce to talk about the systems that have to be in place in the office in order to make that conversation now turn into a valid POLST form and that's submitted to the registry.
Thank you, Gary. That's wonderful. What an insightful description of how those conversations would go and how we talk about the form. I wanted to start by talking about a story just to illustrate how this can sometimes go in the outpatient setting. And I bring this story up not because it is the best example, but because it is one of my most recent conversations around a POLST form. So this was just last week. I was talking with a patient, and I'm going to call her Kathy for the sake of telling this story. Kathy is fairly new to my practice. She's a 65-year-old woman that I took care of her mother when her mother was dying. And then when one of my colleagues left, I started taking care of Kathy as well. And Kathy had a lung cancer that was resected a couple of years ago. And since that time, she has had progressive pulmonary problems with worsening COPD. She had been in the hospital several times this winter and with exacerbations of her COPD. And each time people had talked about things like her POLST form, and that had come up, but she really wanted full treatment and been in that spot. I was seeing her for a routine clinic follow-up and going through various different aspects of her health, her 27-long problem list, and dealing with lots of chronic illnesses. But at this clinic visit was one of the first times that her husband came in. And so being pretty new to meeting Kathy, even though I had known her for years with her mom, this was the first time I'd ever met her husband. And her husband starts asking questions about why she can't breathe, why she can't function well, how things are going, and why she's so sleepy. And as we're talking through that, and I start looking at her medication list and all of the different parts of her multiple medications and polypharmacy, he says, why would you take away some of her medications? Don't you think that she's dying? Well, right there, we've opened the door for a goals of care conversation that hadn't happened well in any of the previous hospitalizations and hadn't happened previously because I was new to taking care of her as well. So Gary talks about this wonderful way of opening these conversations in the primary care setting and the ideal. And I'm putting forward also another part of that, which is maybe the reality that happens to so many of us in the primary care setting where it doesn't happen in the ideal. It happens at about 18 minutes into the 20-minute office visit, but it's the perfect time to have that conversation with just the right people there. So of course we have it, and we start to go through, you know, what that would look like and what that conversation would be, and what are the goals for both Kathy and her husband. And we end up filling out a POLST form in that process. And I wish that I could say all of my goals of care conversations are ideal and that I'm doing them ahead of time, but so often they do come up when it's the right time. Not because I planned it just right, but because it was right for the patient. It was right for the patient and the family. So I want to bring up, what do you do in those settings? And what do you do when you don't have time? Because that may be our reality. So in that setting, I pop out of my room and ask my nurse or MA to get me a POLST form. That signals to them, uh-oh, the time limit for our 20-minute office visit may be just a little bit off here. And they know that we're going to be doing things a little bit differently. We're going to be perhaps running a little bit over. But we get our POLST form, we fill it out. And the other piece that you need to have in place in a system then is when we're done with the office visit and we're already a little late because that conversation maybe put us back a little in terms of our timing, who's going to copy that POLST form? Because the original needs to go with the patient. So we need to make sure then that my staff know what's going to happen in each of your settings. The provider is going to be having that conversation. The staff needs to know where the form is. They need to know once it's filled out that what's going to happen to it, that the original goes with the patient, that the health system needs to have a copy of it, and that it's going to be sent to the registry. So part of our implementation has been just making sure that everyone in our practice, and we're a fairly large practice, knows how that works, knows that that's going to need to happen, because we want it to go smoothly. We don't want it to not get sent to the registry. I don't want to send a patient out to the front desk with the POLST form in hand because I'm afraid it won't make it to get copied by the front desk. So having those pieces in place has been really important for us. The other piece, like Susan had mentioned before, is how's that going to be integrated into your electronic health record? Are we going to have that on our problem and medication list? Are we going to have that on the header across the top? And having that really clear and shared within the system so everybody knows where to have that. The other piece that I wanted to bring up was around trusting our staff conversations with this. I also work with a hospice, and we have lots of folks at our long-term care facility, so knowing that these conversations will happen in different places over time, and that knowing people can be using videos like the one we talked about, the Understanding POLST, that our staff can be well trained to begin these conversations and then be handing that off to me as the provider to be finishing the POLST form, but they've already opened that up and done a lot of that work. We don't have the resources in a rural community like Klamath Falls for experts, and I'm going to use experts in quotes, to be having those conversations all the time. Most often those are going to be in the primary care setting, but even in the primary care setting we need to use other people to help. Our social workers in hospice, our nurses in hospice, they're going to be helping having these conversations. And so being able to think about the ideal place for where these happen, and if you're in a rural area or you're in a busy health system, how you integrate the different members of your healthcare team to make it happen smoothly, to put all the pieces into place, and to be trained and to know what's going to happen to the form and to know what's going to happen for the conversation itself. So that's the piece I wanted to bring in. Make sure you get all the pieces in place and that your whole system knows how that's going to go in different points of time and different transitions of care. So thank you.
Okay, thank you to all the presenters. Now is Q&A time. So we do have one question up, but I expect we'll get more. Again, you can use the questions pane in the GoToWebinar control panel to type in those questions. The first one that we have is, what about a child with a serious or terminal illness? Is a POLST form appropriate in that case?
This is Susan, and yes, in the Oregon POLST registry, we have forms entered by people in behalf of children, people under the age of 18. It is less than 1% of the forms. But if a child, infant, baby, adolescent, is qualifying because they are in close proximity to death and will not grow up, then they are a candidate for a POLST form, even though they are under age 18, where they would not be a candidate for an advanced directive. But medical orders can be written for people of any age. It is about what chapter of your life you're in, not your age. So you can be 1-year-old, you can be 99, and you can be a candidate for a POLST form because it's not about your age, it's about how close you are till the end of your life.
All right, so we had a couple more questions. One was, yes, the slides and recording will be available after the webinar today. But the other, a little bit more meatier question, was if maybe our guest presenters could talk about the workflow process in their clinic. So particularly, Joyce, you mentioned sort of someone else starting these conversations and then handing them off. Can you talk about what exactly that looks like?
Sure, I'd be happy to. So one of the most common places where we have that conversation with different members of the healthcare team starting that is in our hospice setting. So we have social workers and nurses, RNs, in our hospice setting who are trained and comfortable with having those conversations, and they will have the conversation with patient and family, be able to document and describe how that conversation went in the medical care, and then share that back to the provider to sign the POLST form. And that is something where we found that in different settings, if that is not a team member that a provider is working closely with, if they don't have access to see how that conversation went, that it was a trained person who has that conversation well and frequently, they don't have access to see what the components were in the medical record, then they're not going to be comfortable signing a POLST form with that. And that was happening in one of our long-term care facilities several years ago, that they needed to fill out POLST forms for their patients in the long-term care facility, and were starting them and then sending them to providers with no documentation, no understanding of who had the conversation or how, and people were very uncomfortable with that, and it wasn't really an appropriate process. So you need to put a lot of different pieces in place if you're going to build that into how your healthcare team works together. But you can do so, and you need to do so probably by doing some shared training as a team, so that the team members trust each other and can understand what's going to go into that conversation, so that it's safe, that it really does represent the patient's wishes and goes in the way it should.
I would say in our clinic, we see a lot of POLST conversations that are initiated through hospice, certainly, and I feel confident with those POLST forms when they come in that the hospice nurse had a thorough and in-depth conversation. We also have a community health worker who has raised the issue of POLST and maybe even had the patient bring in a POLST form that's not filled out, but preps that patient for that conversation when they come in. And then sometimes we have orders will show up from an assisted living facility, and included in the orders packet is a POLST form. And that, I think, is not appropriate for me to just fill that out when I'm filling out admission orders without having a conversation with the patient. And so in that case, I do postpone filling out that form until I'm able to have a conversation with the patient. I've found that a patient who's just handed a form and told to fill it out, when they bring that form to me filled out, and we have a conversation about what those checkboxes mean, we almost always change what their wishes are after they've had a conversation and understand what they're actually asking for. And so I agree with Joyce that it's really important that somebody who knows what resuscitation looks like and what comfort measures versus limited treatment versus full treatment looks like, and what the options for long-term, short-term, or no artificial nutrition actually looks like, it's really important for that description to be part of that conversation when the patient's making an informed decision.
Excellent, thanks. And then we got a couple of questions that I'm going to kind of smoosh into one, which is related to documentation and the registry. So are folks finding that there is a spot in the EMR to indicate if someone has declined a POLST form? And then another question was, can folks look at the POLST registry to determine if our patients already have a POLST in place, and if they do, how does that sort of work into the workflow? Do you check in on it? And if there's anyone who could speak to those points, that'd be great.
Well, this is Susan, and I'd be happy to take on a little bit of what's in the future, including what's in the present. In the present, of course, the Oregon POLST Registry has both an emergency crisis line for a patient to assure that in a crisis, EMS can get information, emergency departments can get information. But there's also a back line for daytime use. It's on the back of the actual POLST form that would get a form to a nursing home that the patient had been discharged and it couldn't seem to be found, and give them a copy. So there are multiple ways to get information where it needs to be. In the future, we anticipate more use of electronic registry systems and electronic medical records in tying in and communicating. We are in the process of developing an electronic system that would allow a preparer to have one part of a conversation and send it to the inbox of the attending physician. We are in the process of designing a system that would have two-way communication with the registry and tell you that a week ago in another hospital, a patient had completed a POLST form. Those are directions for the future, but all of us want these conversations to be thoughtful, accurately recorded, and ultimately patient wishes are honored. Thank you so much. I notice we're at 9 o'clock.
Yeah, thank you. Thank you so much to the presenters today, and for the folks who sent in their questions. There are some resources. Again, these are also posted on the Institute website. Folks who attended the webinar today will get an email that links them to the recording and the resources. I want to thank everyone for their participation in the webinar today, and I hope everyone has a wonderful Wednesday.